Hello, everyone, and welcome to today's Journal Club. Briefly, we will be discussing a paper by Denton and colleagues who evaluate cannabinoid signaling and ALS pathophysiology. Leading our discussion today will be Dr. Phil Molloy, a rheumatologist who continues to be very active in caring for patients, and we greatly appreciate his continued support despite being retired. Dr. Jehan Marcoux, many of you may know him, a cannabinoid researcher who continues to wow us with his writings. You better check out, see what he's been writing lately. Dr. Len Kamen is a physiatrist from Jefferson University. He may be joining us. He does see patients in the morning and has a quick lunch break, and sometimes he tries to join us. So he may pop in. Next slide, please. Those of you who might be new to the program, I'm the CEO of Physicians Research Center Plus. It has 3 areas of expertise. SALIS is our clinical trial branch. We do phase 2 through 4 clinical trials. Buds Info is our analytics pillar, and Cerium is our education pillar. And Cerium is designed for the busy healthcare provider who wants to understand cannabis and its derivatives through the lens of science. Next slide. Okay, so I know some of you who may be attending have already done this. If you have, thank you so much. If you haven't, please scan the QR code, and this helps us understand, like those of you who are actually participating in the Journal Club. So thank you. The next slide, please. And now I hand it over to Dr. Marcoux.
All right, hello everyone. Thank you for joining. You are in the Cerium Journal Club Zoom room, and the mission and vision of this gathering is to support the education of healthcare professionals such as yourself with discussions of published research, and we do our best to approach each article, regardless of the topic, with consistency, fairness, and transparency. Please share this link if you clicked on a Zoom link or you have an invitation. That's our permanent Zoom room link for these clubs. Please share it with any interested colleagues who you think might enjoy this. These videos are also uploaded to YouTube. And again, just some wise words here, Dr. Molloy, I'm going to speak to. So, the purpose of our journal club, again, is to educate, raise awareness, and engage in professional exchange. We're not recommending policy or regulatory decisions. We don't have a skin in the game, as it were, or agenda, other than education and sharing the information that is published. So our featured article is on amyotrophic lateral sclerosis, the endocannabinoid system, and exogenous cannabinoids, current state and clinical implications, which was published by Denton, Carter, and as well as Ethan Russo, which are 3 notable characters in this area. So, and Dr. Molloy, feel free to jump in whenever you like.
Sure.
Amyotrophic lateral sclerosis is a progressive neurodegenerative motor neuron disease popularized by Lou Gehrig's, who gave a very famous speech after being diagnosed with the condition. So how did he find out that he had Lou Gehrig's disease? Well, his batting average dipped below 300, and this was a giant of a man who was well known for performing at the highest level even when injured. And basically he got the diagnosis and passed away 2 years later. There is no cure, and it is typically fatal between 2 and 5 years. And as the paper highlights, there's no unifying understanding of the pathogenesis of the disease apart from the death of motor neurons, the neurons that control muscle movement. There are some approved products to address different symptoms. Dr. Molloy, can you tell me about some of these symptoms, such as dysphagia and
Yes,
yeah.
sure. Thanks. Yeah, we do have a slide going over the prevalence of specific symptoms coming up soon. But the FDA-approved products that exist today really are for symptom management, like dry eyes, problems with saliva, speech, sleep, energy, things like that. So far, there is no intervention known to extend life expectancy, although there are alleged disease-modifying drugs. As the Journal Club goes forward, my recommendation to the attendees here, when we talk about treating ALS, think symptoms and think life expectancy. Mitigating symptoms, we have some options. Extending life expectancy, I don't know. There is one treatment out there, as you can see from the second to the last bullet, that has been shown to extend life expectancy by somewhere between 2 and 3 months. Kind of a depressing disease. When I when I was a newly graduated medical student and started my internship, and showed up for day one of my internship, my first patient I was introduced to was an ALS patient on a ventilator. My baptism was managing his ventilator.
Mm. So, why are we interested in cannabis and why might we consider it an ALS? Well, looking at the medical literature for cannabis and again, the broader spectrum of cannabinoids, there are many symptoms that might be suitable, including pain and fatigue, sleep issues, cachexia, depression, anxiety. However, just based on the literature I've read over the years, I would say I feel that spasticity and drooling are two of the best suited, say, treatments for a THC-rich product. There are, some of the side effects of cannabis other patients or recreational users may not appreciate, but the dry mouth it causes is actually one of the side effects that patients look for because of the difficulty swallowing. So I always like finding things like that, like one person's side effect is another person's therapeutic effect. But also spasticity is an important condition. And when we think about products like Sativex or the nabiximols or muscle spasms and things like that, I really feel that there's strong promise in these two areas. Phil, any comments on some of these conditions?
Well, yes, we do have an approved product in many countries for spasticity associated with MS, as you alluded to. And that estimated 59% of ALS patients have significant pain. That's a low estimate. Um, Other registries of ALS patients show that it could be as high as 75 or even 85% have pain requiring attention, medical attention. So that's a minimum.
So, so that's great. We have some promising symptomology treatment, but why should we care about symptomology treatment? I believe it's because there actually might be some disease modifying effects, particularly related to certain neuroprotective mechanisms that may add up to prolonged survival in some cases. And we're going to talk about some of the really interesting animal research and even some preliminary findings in human beings from clinical work that may help us understand why we should care about cannabinoids in ALS. So, Teresa, you're our resident epidemiologist, so I'm going to try to do a little epidemiology karaoke, and you let me know if I'm hitting the notes right. But I was surprised to learn that about 5 out of 100,000 people in the population could have a diagnosis of this. It affects slightly more men than women. The most common ages of onset detection or reporting is between 40 and 60 years old. 90% of it is thought to be, or more than 90% of it is thought to be sporadic. There is a strong genetic component, and there's even a genetic mouse model that is really predictive. And there's some interesting treatments that are being developed around, as you know, oligonucleotide therapies and things like that. What is really interesting is that the condition is known to cluster. So in some of the early work, it was thought that it was more common in urban and agricultural areas. And there are thoughts that the incident is increasing. However, it could be just our ability to detect it, the tools to diagnose it are better. So what increases your risk from a public health standpoint? Ever having smoked doubles the risk, and still smoking triples the risk. These next ones are very interesting to me. High dietary fat, high incident in athletic people, and high glutamate intake are all associated with increasing risk. I do have a bit of a theory that this may be sort of perhaps an artifact or an indication. If you think of Lou Gehrig, you have a high performance athlete who's probably eating a lot of steaks and chops, a lot of protein, high fat diet, maybe taking supplements for muscle recovery like glutamate. Are these just, and probably again, more frequently visiting health professionals about performance and his health. And so you might see people who are more athletic and performing at a high level might have more access to healthcare, and so it makes these factors stand out a little bit more. But also, heavy exposure to petroleum products and heavy metals also increase risk. So I don't know. I don't necessarily think that high dietary fat and athleticism and glutamate intake are causative, but they are very interesting indicators with getting a diagnosis of ALS.
It's so rare, it's hard to prove the associations. 5 per 100,000, 50 per million. So there's 100 to 200 in the United States. It's a rare disease still. And as we've had in previous journal clubs, I'm sure you guys remember that noting an association doesn't say anything about cause and effect.
Teresa, how'd I do? Is there anything you'd like to update or correct about the epidemiology of ALS?
No, it's perfect high level, Jaihan. We could always do an epidemiology deep dive into this. It's actually pretty fascinating because they do like sibling and genetic, but that's more the genetic piece. So, but great job, guys.
Thank you. So, uh, not only was my PhD mentor studying in this field, I also did some advocacy work with Kathy Jordan, who was a friend of mine. She lived for 38 years after her diagnosis, and you can read an article we wrote together about her experience on projectcbd.org. And she said everything changed for her uh, when she was offered a strain of cannabis in Florida. And she used to joke that, you know, the fountain of youth by Ponce de Leon was thought to be in Florida. Maybe this plant grew near it. In fact, she lived so long with a diagnosis of this condition that her Social Security benefits expired, because when you get a condition like this, you get an expiration date, you know, and she lived past her expiration date. The other issue was she kept outliving her neurologist, and so getting access to her medical records and having people available to verify who she was became difficult. And unfortunately, she passed away in 2024, but not before completing a documentary with Andrew Weil about her experience with cannabis and living with the condition. What was interesting was when we were discussing this issue, it brought up a lot of the difficulties in diagnosing the condition. And is what we would have loved to have known is, was there a genetic factor that helped to live so long with this condition? Was there a genetic factor that associated with the effectiveness of cannabis, that if it was supporting the quality of life and long-term, extending the life expectancy? So there's a lot of questions. Definitely a stunning case report history, and I encourage you to read more about her or check out some videos on YouTube. It's a fascinating story. So this article is organized, this review, into a couple different sections, and we'll touch upon them, including the introduction, their review of the endocannabinoid system, the animal and preclinical data, which is fascinating, the ECS as biomarkers, the endocannabinoid system and all of its components. Is it going up? Is it going down? How is the tone changing in response to these conditions? As well as some preliminary human data. And we'll end with some of the author's conclusions, which I think are extremely appropriate for the state of the research. So I thought this table was a really great table they put together, Phil. They have on the left different components, cannabinoids, terpenes, and these cannaflavins, some of their mechanisms of action and the symptomatic benefit. Because as you know, when you take a cannabis product that is an extract, you're taking sort of a shotgun, a meteor shower of different compounds that can have different impacts on your physiology, whether it's anti-inflammatory, whether it's immunomodulatory. But Phil, was there anything that sort of stood out to you about this table?
No, this is the only table in the paper, and to me, this was a justification of even asking the question, why look at cannabis in ALS? And I think this table is presented to the reader to answer that question, essentially. That's what this table's for.
Absolutely. And my own father actually uses a rosemary extract, the alpha pinene, for the acetylcholinesterase effects, is what he claims. He thinks it absolutely helps with, the mental clarity, and provides other benefits. Um, so I think that some
So
of these,
Jayhan, would that be the same as walking past your rosemary bush and eating a little bit of it every day? I mean,
probably, I think so. I mean,
you get the extract, right? I mean, so that's the whole plant. It's
I've done my own case report. I did put some in my jacket pocket for a presentation a few times. Just think that maybe the pinene will help me stick to the bullet points.
for sure, for sure.
Right.
Sorry to digress. Go ahead.
No, it's fantastic. I really like that they put the acidic cannabinoids in there too, but there is a little bit of a theme here: anti-inflammatory, neuroprotective, antioxidant. Um, we see a lot of those different activities, and cannabinoids, while they might look similar and come from the same plant, don't target the same anti-inflammatory pathways, right? Like CBD and THC target different inflammatory pathways. One goes through the CB2 receptor, one goes through TNF alpha. And so I think that's an important thing to keep in mind, that this isn't just overloading one pathway for inflammation. They're converging on a physiological outcome, which I think further supports the author's sort of theory.
And if you just go back 1 second, if you go back to the second column, you see neuroprotective over and over again, like 3 or 4 times. And that's based on, am I right, animal data mostly. And there's animal stroke data showing that certain cannabinoids actually favorably influence um, damage, neuron damage in models of neuronal injury.
And even
So
with
that's another reason. That's another reason to ask, I wonder if this has a role in ALS.
100%, and there are some human petri dish assays where they took human brain cells and microglial cells from surgery and put cannabinoids on them and challenged them. So they have the whole animal studies, and they have human brain cells and petri dish studies looking at the neuroprotective mechanisms. There are some videos of time-lapse petri dishes online looking at this that are really fascinating. So the animal models were quite striking. So my mentor from grad school, Mary Abood, published some of the, I would call it groundbreaking, but again, I have an implicit bias. But she published with Greg Carter the first hardcore evidence, and that was in SOD1 mice that had basically a animal form of Lou Gehrig's disease. And when they gave them pure THC, the animals lived as long as wild type animals. Well, normally when the animal gets this, it passes away quickly. Now, there are some caveats to the research model. Normally, in a lab animal cage, there's food on the ceiling and they reach up and kind of nibble. For these animals, there was a protein sort of liquid gel pack that they could crawl and eat. But again, they're living and they're living as long as wild type mice when given THC. This research was extremely popular 20 years ago and even was actually the target of animal rights activists because the research was making headlines and so they had to tighten up security because this research was making so many waves at the time. And and again, with THC, it's a strong indication that cannabinoid receptors are involved. Perhaps one of the best indications that it is related to a CB1 or even CB2 stimulation. That being said, where cannabinoid receptors are stimulated, it probably implicates endocannabinoids. And so there are thoughts that endocannabinoids respond to different physiological changes in our system. They respond to disease, exercise, even your mental state. So if you watch, they even have shown people certain types of movies. They're not appropriate. I won't mention them here, but they found that they were able to alter the transient effects of endocannabinoids in the blood. And so they're thinking that certain endocannabinoids could also be biomarkers, an indication. And I have always wanted there to be able to go to Quest Diagnostics or whatever and get an endocannabinoid panel. I think that would be really amazing. However, there is limited human experience to help us understand the possible benefits. There's certainly mechanistic data and very promising data from our cousins, the humble mice and rats. Now, there are more than one animal models available these days to look at ALS, and some of the studies have shown positive results. Symptomology that's able to be measured in a mouse, as well as lifespan. And the authors discuss this in the article about the compelling evidence in mice and canines for endocannabinoid system abnormalities, including the upregulation of CB2 receptors, accumulation of endocannabinoids in the spinal cord. And this is interesting because endocannabinoids appear to exert anti-glutamatergic and anti-inflammatory actions through CB1 and CB2 receptors, where one of the possible mechanisms is, excitotoxicity. So it might be related to excessive glutamate signaling. So again, adding more support for this theory of the endocannabinoid system being involved. And this isn't the only condition, for example, where CB2 receptors have been demonstrated to be upregulated. During traumatic head injuries in animals, and possibly humans, and primates, and any real species they've looked at, CB2 receptors generally transiently increase in expression in response to disease or injury. So this may make a lot of sense.
Yeah, when I first started thinking about cannabinoids and ALS, I said, come on, I was cynical and suspicious and not, saying this is people are grasping at straws here. But if you think about what we know about these animal models, there is a long history of showing neuronal protection with some of the endocannabinoids. I'm not sure if it's been shown for phyto or exogenous cannabinoids, but we do know that there is a story here that makes me want to step back and say, all right, show me more. You have my attention. Let's see what we know about animals and then humans. So section 3, if anybody has printed this article up, section 3 summarizes in this review article what we know about animal data so far. And we're not going to talk about section 4, which is Can you measure endocannabinoid levels? It could be a biomarker for progression. But section 5 is what we know so far about humans, and that's what we're going to jump into next.
Absolutely. So section 5 is really interesting, and I'd like to talk about a little bit about neuroprotection before we jump in, and because I've definitely received the criticism, how can it be neuroprotective? It's associated with mental health issues. It's associated with affecting memory, recall, and one of the analogies, big analogy guy I say, is if you have a damaged road and you want to repair it, do you keep driving on it or do you shut it down and redirect traffic? And so when you think about excessive, glutamate excitotoxicity, where neurons are sort of firing themselves to death because of an injury or insult or pathology, the endocannabinoid system shuts down that signaling to sort of let repairs begin. That's why the CB2 receptor increases in expression, right? I think of it like if you twist your ankle and your ankle swells up, your body is shutting down the use of that so repairs can be made or there's time to heal. But anyway, fun analogy to take with you. So Dr. Molloy, being the MD, please take us through some of the human evidence.
Yeah, that's on the next slide, actually. So what I did was on the next slide was I culled from section 5 some of the references. It's full of references. As you can see, if you read down these 4 or 5 references from section 5, they're small numbers. The first one is just a survey of 13 patients who were using cannabis products. It's just patient-reported data. It's comparing symptoms before and after using medical cannabis. The Biximol Sativex, approved for MS spasticity in many countries, has been studied in 2 ALS studies. And one was retrospective and one was prospective, 32 patients in one, 60 patients in another. By the way, all these studies document the reasonable tolerability. I suppose it's in the context of ALS. I wouldn't complain about anything with ALS, but these patients did not report any side effects. I'm not sure what the modified Ashworth score is. It's a pain. I think it's a pain metric. I'm not 100% certain. It's been a while since I looked at this study. The middle bullet is another survey, 127 patients, open users of a CBG dominant preparation, comparing their pain scores before and after using this preparation, showing improved symptoms. So you're getting the drift here is that symptoms are being patient reported is the dominant literature right now, subjective, and these studies are not long enough or large enough to make a comment about longevity and life expectancy. The second to the bottom one, the 2024 study, is a placebo-controlled prospective randomized control study, CBG dominant tincture, showed that it helped 2 symptoms and was well tolerated. And the last one is a review article of medical cannabis users with ALS. Obviously, if there's only 200 ALS patients in the United States, we're not going to get big numbers. We're stuck. So what we have is animal data, we have survey data, we have patient-reported outcomes, and we don't have anything on longevity in humans right now. So this is an example. If you read section 5, if you print this off, if those of you in the audience are neurologists or have special interest in this, there are links to all these articles in the bibliography.
Yeah, and Phil, just one clarification. The Ashworth score, I believe, measures muscle tone.
Okay.
And one of our attendees, Dr. Stein, chimed in that it is helpful for measuring spasticity, which is muscle muscle tone as well.
Yeah.
So look at that. We
Good.
outsourced it to the group. It worked out.
Excellent.
Wonderful. And
So enough,
yeah,
yeah, there are enough references to get your attention and say, wish we could do a trial.
and enough out there about different cannabinoid products. And I thought that was interesting when you have the big category of cannabis,
Mm,
whatever that is, however they define it, everything that can be made from cannabis, we see something. And as they get more specific, THC CBD extract. We see that that works. Oh, a CBG dominant extract. They're seeing different sort of resolution or precision or um, you know these constellation of benefits, which I think is really, really promising. So
If you were
to
going to study this, Jehan, would you study an extract, or would you use a whole plant?
I think the answer to that is if I could wave a magic wand, I would have
Yeah,
probably two or three groups. One would be the ad libitum, which would be they can use whatever they want as much as they want, and
right.
you just monitor what that is, and that would be sort of one big group. And the other one, I think, CBG and CBG extracts, CBG rich extracts. I think that if people didn't have so much fatigue from CBD marketing, I think CBG would offer tremendous benefits, and it just has a remarkable profile. I actually have an article in Rolling Stone right now that they're considering on that Ethan Russo helped me write about CBG and some of its remarkable effects. One of the reasons I really think that I would do a trial on CBG for conditions like ALS is because it also is a non-sedative um, pain reliever. So it acts through these different channels that don't have the same profile that every other painkiller has. So I think it holds tremendous promise in that area. So yeah, so I would love to do just kind of maybe two groups. One would be use whatever you want, and a CBG
Yeah.
formulated product. Those would be the two most like groups I'd be interested in studying. And
I like that ad libitum study. We've seen that in previous journal clubs. There
yeah,
are protocols written with ad libitum, and then you check levels for what it's worth, and there's so
yeah,
much variability. So if the subject is deciding how much they need, there's actually an advantage to that study design. So that
yeah. And
if
it might
this,
they might then they might want to use an administration form we hadn't considered or known was available with a certain product profile. So for me, it's also about,
right,
do these patients really like smoking the product, vaporizing it? Would they prefer to have a
yeah,
tropical fruit flavored lozenge that they can,
hmm
you know, to deliver these products? Like
right.
what is the preferred, um, method of consumption? I think we can only assume at this point.
So from the conclusion of this study, that's where these bullets come from. Who would have predicted this? I wouldn't have before we started down this path, but here's a lot of interest in cannabis-directed therapies for ALS, for symptoms and more. There's a need for rigorously designed clinical studies, because right now we just have observational studies and case reports. There is a basis for FDA approval for cannabis-based products, and you can see in the parentheses there are products on the market right now that have received FDA approval. Um, and the tempting last bullet is, I think we all know the answer to it. What challenges? The challenges are this is a rare disease, and we're not going to have big numbers. There's no way you're going to have a study like you do for lipids or cardiovascular disease or HIV or something with those kind of numbers. So we're going to have careful endpoints, small numbers. If somebody lives an extra 3, 4, 5 months, it might be significant. It might be scatter. We'll need somebody good at statistics moving forward. So I wonder if there's any studies looking at this. Well, stay tuned, right?
Mm. I definitely see the effect it has on lifespan. You know, you think about people who get this diagnosis and 1, 2, 3,
Mm.
maybe 5 years max. I think that is also an incredible difficulty. And then add the bureaucracy to that with um, trying to get a trial going, let alone a trial with a Schedule One product that is not, say, a Schedule 3 product or what have you. I think it prevents doing things in a timely manner. So if only
Right,
there could be an orphan drug status for that could be leveraged or something like it to expedite these trials. I think
Yeah. So for me, the biggest challenge is the delay in diagnosis, right? We see that with a lot of different illnesses. And so if you can identify symptoms, and as a big data, real world data generation person, if you can identify the symptoms as a group, which I have done, and then you can kind of identify those patients within some of these centers who may,
yeah,
before they have the actual diagnosis, because the delay in diagnosis is really pretty big for this population.
right,
That's my understanding. And
yeah,
so if you could get them earlier, especially if it really is disease modifying, the sooner you get to them, the longer, and I guess that's where I was going with this, Jahan, right? When you're talking about lifespan, you know, um, where are they in their disease? And so
right.
then if you can get them sooner, then, and it really does change, they can live life longer. So,
I really like that because maybe it's about changing the scope of recruitment. And if we had an association, let's say with an endocannabinoid profile, just making stuff up here for our conversation, you could say anyone who has, you know, a type, this type of endocannabinoid profile, we want to recruit them and look at, the effect of cannabinoids and underlying conditions. Because so we have to think about, that's why biomarkers are useful in establishing those, is it doesn't necessarily mean you have the condition, but you definitely are releasing something that looks like it. Your
right,
body
that's right.
looks.
Yeah,
Because like when you look at MS and
yeah,
cannabis, so there's other spasticity illnesses.
yeah,
Um, so yeah, so there's
yeah,
promise, and I guess funding is always an issue, right? I mean, these
yeah.
studies, you can do an awesome study, but it requires access and funding,
Yeah, and if
Yeah.
anyone wants to write us a check, we'd be happy
All
to engage in this research.
right.
So the authors state, which again, as we have discussed and has been true for way too long, is that there have been no prospective randomized controlled studies investigating the potential of cannabinoids as disease modifying therapies in patients with ALS. But there has been several small studies suggesting a role in symptom management. A cannabis-based formulation could be a safe and tolerable therapy that offers palliation of several symptoms greatly affecting the quality of life of patients with ALS. And I think that their review absolutely supports this conclusion. I was not left with, it's hard to mention,
doubting with
yeah, it's
doubt.
hard to mention a gap. Like, I think that if you're writing a research protocol for approval, they would have pretty much all the preclinical data that you could want at this point without having a major multi-center study. Um, Important thing to remember, and I think, as Dr. Molloy, our resident skeptic, is that there are still unexpected therapeutic potentiality in different conditions. So as health professionals, keep an eye out for the possible disease modifying effects of ab libitum cannabis use, as well as specific products. I definitely believe that clinicians are on the forefront of identifying these patterns and looking at, helping us find better precision or resolution So that we're not just staring at some blurry red dot. We can say, oh, that is a planet, that is Mars. We can start to, again, get more clarity on what it is we're observing. Some of the strengths and weaknesses of the article. Obviously, the strength is that this was comprehensive. The authors are very credible, long history of great research in the sciences. The weaknesses is that it raises more questions than answers, and there was no new data in this article. But again, I think that it's the available information that we have. And there are more articles like this out there. There are more thematic articles. There's a review on ALS and pain, which is really, really well done, and makes an argument for looking specifically at ALS and pain to understand those interactions. Then there's even more, and this was so cool. Phil, please tell us about
Yeah,
these platform trials.
well, it's coordinated at the Mass General Hospital in Boston, and it's a novel way to, in real time, to say that you have a rare disease and you're going to enroll people on it to identify therapeutic interventions which are destined not to work. So it's claimed, the people who wrote this platform, it claims that it can take the cost of bringing drugs to market down by 30 to 50%. The time to do the study can be decreased by about 50%, and recruitment is a lot easier when you do this. So the purpose of this platform trial, I have no idea if it's who Healy is. It could be our governor in Massachusetts, but I'm not sure about that. We do have our governor's name is Healy. Um, I'm not sure if she has anything to do with this, but it is a mechanism of identifying early on interventions that you can bail out of. And the analogy I gave Jehan on the phone when we talked recently is if it's in the ninth inning and you're down 20 to 1, you probably know the game is over by then. It's not a perfect analogy, but if when you collect data in real time, are you getting enough signals that we can bail out? So the first four studies were published on the Healy platform recently on not cannabis related products, just for other products where there was a basic science justification to look at them on neuronal death and prolonging neuronal health. And sadly, they were all negative studies, but they were able to call those studies right away and not put more money, time, and patience into these trials. So there are four ALS interventions which were able to be bailed out of efficiently. Not that that's great news, but the fact that there's a mechanism to streamline clinical trials in rare diseases is a good thing. So this is all published within the past few months. There's a 2025 publications.
Excellent, especially
Now,
for formulating a complex cannabis product. It might make a lot of sense in working with cannabinoids. Is if we're not getting a great response with this formulation, we don't need to, continue to make a pharmaceutical grade product and continue down this path. Teresa.
And if you start out of the starting gate testing more than one products, maybe one or two or some of these products, but not all of them, will die on the vine quickly, and maybe some will survive, and the studies will go on longer, and some.
Great point. Sorry, Teresa, you
no,
had.
no, no, it's all I mean, you're saying exactly what I would have been saying. I also, these are all published, Phil. I have to check them out.
Um, no, no, they're not all published, as if they
Okay.
were completed studies.
Okay. Yeah. Did you use clinicaltrials.gov for this?
Yes,
Yeah. Okay.
I use
Because I use
clinical
that a
trials.
lot. Awesome.
Yeah,
I'll check it out because sometimes they'll have a high level summary in there.
yeah, and this is only 4 months ago. his
Perfect.
publication in JAMA. Yeah.
And there's even more. So, uh, Phil did
Yeah.
some sleuthing on the internet and found some interesting comments made between Dr. Russo and Canerda, who seem to be planning an ALS study, a product that is whole plant derived to address many ALS symptoms, including quality of life, and cannaflavins are a key ingredient. Um,
Okay, so Jahan, I would like to do a poll. So I'm going to say something. With all of my years of drug development and being in pharma and in the space, and you start to publish early before you actually do the study about the unmet need and all these things.
Yeah.
I am not surprised, and I'd love to know from the audience if anyone is surprised at the fact that, Dr. Russo's, published this paper that we just talked about and is now looking to, because it's almost like he's generating the interest and showing the rationale as to why there should be a study.
and feel free to unmute yourselves if you'd like, or you can.
I'm optimistic there's going to be positive results on symptoms.
Yeah, no,
I
I'm
don't
optimistic as well. I think it's awesome. Yeah.
I don't
But I'm
know
not
how you
surprised that he's doing this. I guess that was my point.
know. And he has a financial interest in Canada. That's his company, by the
Ah,
way.
okay. Okay.
Yeah, he owns that company. It's a research company in cannabis. But I don't know how you take a disease that's so rare and make a conclusion on life expectancy. I don't know how you
That could be
can.
an exploratory outcome. I don't know if you
Yeah,
actually
it
do
is.
that.
It is a
You just want
secondary.
to you
Um,
just want to change symptoms. You just want to put quality of life measures in it to show that you actually can change.
Yeah,
That's my favorite line, right? Are we just prolonging an already miserable existence, or are we actually really doing something, right? I mean,
yeah.
that's really the key. I see Al is he like, hey,
Yeah, I was thinking, yeah, quality of life here. But again, some of the things we keep coming back to is you got such a small group here to work with, and then you've got such variety, as we see with this topic, in doses, routes, frequency, that it's really hard to pin down so that we can interpret it. So uh, the kind of environment that this topic lives in it makes real challenges for the research. I think there's lots of benefits that we can find, but how do we get to the good methodology of the research to find those results?
yeah, no, it's so true.
Yes, we 300 case reports that are part of a meta-analysis. I would,
Well, I mean, I think that if you do it, you partner with, I mean, there are ways of doing it, right? It just takes funding and time. You part with the advocacy groups, I mean, there is an ALS group. I mean, I happen to donate to it every year. So there are ways of getting connected through, through that. There are people who are tested, to see if they have the gene or not. So there are avenues. Um, Maybe they would be willing to participate. I mean, it's possible. I think it would be definitely not an easy journey, but it's definitely possible.
and we also got a comment that our attendees are not surprised he's doing this at all, and that he is the perfect person to do neuro research as a pediatric neurologist, is Dr. Russo's background. But uh, our attendee, Nurse Wendy, she is surprised he didn't choose a disease that has a larger patient population for these efforts. And I think that that's an interesting uh, philosophy, right? Maybe start with our largest need and develop products for there using his decades of experience. But you go where your passion is and you go where the funding is, and where those two intersect.
Well, there's so many patients with stroke, and I could envision a study. The numbers are huge. Standard of care plus placebo, standard of care plus a cannabis product.
I like this idea.
Looking at
Yeah, no,
di
yeah.
disability, survival, neuronal cell death.
If we see a study published with these ideas, we'll know that you stole them from this journal club.
But yeah,
Or just ask
yeah,
us to consult with you. That would be awesome.
Uh, Dr.
yeah.
Stein, I see you're unmuted. I assume you're ready.
Thanks. Yeah, thanks, Jahan. You know, the first thing I noticed about this study is that it's published in the journal Muscle and Nerve, which is the premier journal that is read by neuromuscular specialists. So I'm sure so there's no accident. The ALS experts around the world that may have little to no information on cannabis therapy will be introduced to the idea of cannabis therapy for ALS because they all read Muscle and Nerve.
That is a great point. Also, if you're going to do a knowledge and attitude survey, I think that I bet there'd be seeing how this might impact views about cannabinoids in the future. I think, yeah, what you say just brings to mind, like, oh, what do clinicians who specialize in this area think about it right now? But that is a great point.
And I think Elizabeth had a comment, Jayan. I can't
Oh,
seem to find it.
Oh yeah, we are running a clinical trial using cannabinoids in concussion. Huge numbers of patients. Funding is tough for sure. Wow, that is awesome, Elizabeth. And um, we would love to do a journal club about some published results. So keep us abreast if if you have preliminary results coming out or you're presenting something at a conference. We would love to learn more. So this brings up, an issue is how a couple of prompts for group discussion here, and it's trying to think how can providers stay up to date on the possibility that cannabis might help with some rare or unexpected conditions in the absence of convincing and concrete published studies. And the additional thing is, are there considerations in recommending interventions involving cannabinoids that may be unproven for these unexpected or rare conditions?
To ponder.
Well, I think Daniel actually brought up a good point, right? So here is the first paper, maybe that's touching it in a well-read paper
Yeah.
from neurologists, and I mean, something like what we're doing now, even if they had access to the recording, right? So they may not have time to actually read the full paper, but if they, had access to this to just sort of like pique their interest and then go back to the paper, because this is short, right? It's short, it's interactive. They get to kind of hear
Yeah.
about it. I think Al
Yeah.
has like with pregnancy, I mean, how do you get these docs involved? I mean, it's such a pregnancy registry and exposure to drugs. He lives in that world. um, it's difficult to connect with the busy healthcare provider, right? So,
One one other thing that I like to remind my colleagues about with not only ALS, but in cancer patients and other illnesses, fatal illnesses, is that when it comes to palliative care, these patients are going to be able to benefit from cannabis therapy at end of life. So being able to identify those patients earlier, like you were saying, Teresa, that may have a symptomatic and longevity benefit is great, but also being able to introduce them to cannabis so that when it comes time for them to have a good death, we have those tools available and they're comfortable using those. So that's another aspect to this.
absolutely. Yep. Thank you.
And when you're out there looking at sources of data, especially stuff gathered with AI or those tools, it's always important, as Teresa has taught me, to look for the figure one, the inclusion exclusion criteria for any sort of, there are this many number of studies and thou shall not say there are more or less. So you always want to know what are the inclusion exclusion criteria, because sometimes studies are published before they're finished, and they get, you know, a DOI number, a Library of Congress number. And so making sure when we tabulate how many studies are out there, having a process for inclusion, exclusion, removing duplicates or other factors. Because let's face it, not all research is created equal, and some studies have never been published, and some studies aren't studies at all. And we just, again, to keep that in mind as we are, you know, just being a little skeptical, and always having a strong bias for data. But I love that we have a PharmD on the call, Ann Berg, and she shared some data from Cannakeys, which is a great website, great resource. But again, I'm always like, how do they generate that number? That sounds like a big number. I'm skeptical of big numbers, so I don't belong to any astronaut.
But it's always worth
Right.
looking at it, right? I mean, I think that that's the key, the key. It's always worth looking at it. Similar to what Phil did. I mean, you know, that's another teachings when I teach students about the literature and everything is, you
Yeah,
know, pulling those references that they used in the paper. You know, looking at, I mean, and Phil, thank you for doing that. It does take time to pull those studies and
yeah,
look at those individual studies that they referenced. I mean, so many times we read a paper and we just take their word for it. Okay, there's 15 studies and we don't pull the papers. But if we take the time to actually pull those papers and see, you know, why they referenced them or what was it
yeah,
about it.
yeah.
So,
One of the symptoms to know if you really are an academic is if you do read the reference list first. So, um, so it's summer times here. So July, your homework assignment is to go to the beach or a barbecue or have some fun. We're not going to do journal club. We do have all these on YouTube, and if you want to email me or other folks or reach out, we can share that link if you have trouble finding it. But they are online. If you search for the Cerium Journal Club, should come up. We have a playlist and everything. But August 5th, we're going to do a very interesting study on the ACP guidelines for cannabis for chronic pain. This is a really cool article. I think it's going to be a very fascinating topic. Phil, do you want to, you identified this article and suggested it.
Well, it's another guidelines article, so it's not presenting primary data, but they have scoured like a Cochrane analysis. This one is fun. So it's currently has cast a wide net, looked at all the studies, observational studies, control studies, and all that stuff, and has tried to make sense of what's out there. What products, what type of pain is more likely to respond. And so it's kind of a useful article, actually.
Excellent.
and if anyone online would like to have a direct email, I do send out an email reminder a few days before, but I need your email. So if that works better for you than finding the information out on LinkedIn when Jehan posts it. And it's also on our website. So if just put it in the chat or send me an email. I think it's at the front, right, Jehan?
Yeah, if you want to put it into the chat real quick for,
Yeah,
And
whatever works. Yeah.
this is an open article. You don't have to subscribe to the Annals of Internal Medicine. It's open and free.
I like the sound of that.
Yeah.
Well, I just want to open the floor. If any attendees have any questions, comments, if they'd like to see another slide, we have minus 4 minutes. We're a little over time, but I just want to make sure everyone had a chance to comment or share anything like that. Otherwise, we can close out the room in a little bit, but
Yeah.
the floor is yours.
I had the privilege of taking care of Kathy Jordan and Bob for a little while. She told me about outliving her 4 neurologists, and she was great. She was great. And it was because of Kathy that we were able to get smokable cannabis approved by the judge advocate in Florida. We had passed medical cannabis legislation here in 2016, but Kathy and Bob, of course, were very active in that type of thing, and they were instrumental in allowing flower to be one of the options for medical patients in Florida. And I had to write a letter to the judge advocate telling them that if flower was available for patients in Florida, would I recommend it? for patients with ALS. And of course, using Kathy and her experience with my act of gold as an example, I felt comfortable supporting flower as an available treatment, whereas some states, don't allow that. So that was fun.
Thank you, Dan. That's fantastic. And I think that was just another dimension of her personality because she also went to places like Tennessee. And I know some people would probably never want to travel to certain states to do, well, let alone think about doing cannabis advocacy, let alone travel with a condition like that to different states to testify and to expose health professionals, the public, and regulators and elected officials to perhaps at the time some uncomfortable ideas. So thank you for sharing that. I think that was an important, very important dimension of her personality is that she was very proactive in getting this in front of people in her experience. It's very impactful. All right. Well, I'll keep the floor open for 10 more seconds and I'll just start, put your tray tables up and your seats in the full upright position as this journal club comes to an end. We definitely appreciate your attendee, your participation, and your feedback. We used to do this journal club in the evenings. We moved it to the afternoons to try it. So we're open to say, if you say, you know what, this time frame works better for me as a health professional, we might just try a few sessions at that time. So feel free to email us with feedback, comments, questions, and even topics you may want us to cover or consider for a future journal club. So,
Yeah, I put the general email in the chat box, Jahan, if anyone has
excellent.
any of those
Yes,
comments.
prctrials@gmail.com. That will get in touch with all of us in one fail click of the send button. But thank you so much. We couldn't have a journal club without you. We really appreciate it. So enjoy the rest of your week. Enjoy some of your summer. And we will hopefully see all of your wonderful faces and images in August.